Neurocognitive disorders. So this section really has a lot to do with neurological conditions that can impact other areas of functioning and might come up in your work with certain client populations. So these are not things that you're going to be diagnosing on your own. These are often disorders that require neurologists and brain scans to diagnose. And a lot of them are going to involve care beyond just your own mental health interventions. So we're not going to go into a great amount of detail in this section. We're just going to hit the highlights. So an important thing to distinguish is, first of all, the idea of delirium. So delirium, particularly related to intoxication and withdrawal, is altered mental state due to that process. And there are some options in terms of acute and persistent delirium that might be going on and specifiers to help if that's related to substance use. Beyond that, we have what we refer to as major and minor neurological disorder. Also, as a side note, my cat is asleep on my lap as I'm recording this lecture, so if you hear him snoring in the background, that's what the strange noise is. So we have major and minor neurological disorders, and really these are similar. They only obviously differ in severity. So we'll start with major neurological disorder, and so this is seeing a decline from a previous level of functioning or in one or more cognitive domain, meaning ability to pay attention, just general daily functioning, issues of learning, memory, language, etc. And it's important to find out what the baseline level of functioning was to track changes in neurological functioning. So it's important to note what somebody's typical developmental expectations would be and then mark changes in terms of their cognitive abilities from there. And really we're looking at the rate and the severity of the decline in their ability to function in different cognitive domains. And so this might be indicated by you as a practitioner, meaning that this might be something that you notice, but maybe the client hasn't picked up on, or it can be something that the client brings to you as a concern because they're noting that impairment. And so obviously this cognitive decline is going to be interfering with their ability to be independent in daily tasks. So they're not able to do things like paying bills, taking medication. These might connect to things like memory loss from Alzheimer's. We'll talk about some of the conditions on the next slide that contribute to this. And this can be with or without any kind of behavioral issue. So this could be with or without psychotic issues, mood issues, substance use issues, etc. And we do have specifier codes to help identify any suspected causes or things that are contributing to this decline. So on the mild side of things, we're just noticing a modest decline in functioning in these domains. And so the mild decline in functioning, again, can be indicated by you as a clinician noticing things or the client bringing these things to you as concerns. But the major difference here is a mild neurocognitive disorder does not interfere with your ability to function on a daily basis. You can still do most things independently. A major neurological disorder, you are not able to function independently in day-to-day tasks. And with mild disorder, this is not only during periods of that delirium, it's all the time. And this can be with or without those behavioral disturbances as well. So looking at the different types of neurological disorders, some of these might sound very familiar to you. And again, none of these are going to be things that you are able to diagnose on your own. You are going to need other medical professionals and specialists involved to really narrow down what's going on and help assign a proper diagnosis. It's really just important to be aware of as clinicians if someone is coming in with these disorders or has this diagnosed while you're working with them. It's important to understand what that experience can be like and what the cognitive decline can be like, so you're noticing that and providing adequate resources, referrals, and supports. So in terms of neurological disorders, Alzheimer's disease, clearly one that's pretty widely known. We're looking at decline in memory and at least one other domain of functioning, and this is a gradual decline over time. This tends to happen more in older adults, although there is an early onset option. Frontotemporal neurological disease has more to do with behavioral symptoms as opposed to memory loss. So this is gradual changes in behavioral symptoms and decline in your ability to complete daily tasks or use language. So as it sounds, we're seeing a lot of decrease in cognitive ability to do with the frontal lobe and the temporal lobes of your brain. And their jobs are doing things like decision-making, impulse control, and emotional regulation. And so we're seeing gradual decline in those things. Lewy bodies, this really has to do with cognition and disrupting patterns of sleep and potentially creating false sensory information in the brain, which show up as hallucinations. Of course, in that we want to rule out schizophrenia because Lewy bodies are specifically a neurological disease that can be diagnosed, whereas schizophrenia would not show up on a brain scan. Vascular disease, so this is something like a stroke, and their cognitive deficits and decreased ability to process or function as a result of some sort of cardiovascular or cerebral vascular, event, right? So you can have a hemorrhagic stroke or a stroke related to a blood clot in the brain, and that impacts the ability to function. Some of that can be temporary and some of that can be permanent. TBIs or traumatic brain injuries are something I feel like we probably heard about before, particularly related to thinking about our veterans or certain industries where TBIs are potentially very common. So important on the mental health side of things is, in addition to things like memory loss and loss of consciousness, TBIs can also contribute to things like disorientation, confusion, lack of emotional regulation, and impulse control, depending on the parts of the brain that were injured in whatever happened. To some degree, HIV can impact neurocognitive functioning. So here we're seeing issues with memory, issues with behavioral and emotional control, to some degree motor-related issues with balance or muscle weakness, and to some degree, sometimes in later stages, executive functioning issues having to do with loss of vision, loss of ability to chew and swallow properly, loss of ability to regulate sleep. So luckily with HIV infection, currently we have a lot of medication that can manage that disease to prevent a lot of those things, but it is potentially something that will come up in the symptomology of HIV. Prion disease is incredibly rare. That's essentially where you get a virus in your brain and it starts eating away at all of your neurons. So in terms of neuroscience, throwback to your undergrad days, in terms of neuroscience, the way that our brains work is we have these neurotransmitters, these chemicals, serotonin, dopamine, norepinephrine, etc., and they travel through our chains of neurons to communicate messages. So this system is really important because it's how we deliver psychiatric medications. We have to be able to use this chain of neurons to help get medication where it needs to go in the brain. And then also, this is how our brain communicates with our need to move our muscles, our need to experience emotion, our need to make sense of sensory information that we're inputting from our environment. So when these neurons are under attack, it disrupts the process. And that means that the action potential, the neurotransmitters, don't really get where they need to go, and that can cause a lot of problems. And so this is where we see a breakdown of like the myelin sheath, the breakdown of the neurons that results in motor functioning deficits and lack of control of muscle movement. So that's prion disease. We see similar things in Parkinson's disease, motor issues specifically related to tremors and stiffness. Again, this Parkinson's disease relates to the myelin sheath that protects the neurons being attacked and broken down. Similarly, that's sort of what happens with Alzheimer's disease too, is that myelin sheath is like the bubble wrap of the neuron, right? It's on the outside. And when that gets damaged or that's eroded away, then there's nothing protecting those neurons from the environment. And so over time, there's damage done because they've lost their bubble wrap, they've lost their protective layer. So in things like Parkinson's disease and Huntington's disease, we see that breakdown at the neuron level of the brain. Parkinson's mostly presents with motor-related issues. Huntington's has to do with nerve cells, and so that can impact a lot of other areas of functioning like mood, memory, those sort of more muscular motor issues, and speech. So a lot of these things are progressive, so they might start mild and progressively get worse with age. And now they have genetic testing where individuals can see if genetically they're prone to have these disorders, because there is a big genetic link in neurological disorders within families. So if your clients' parents or blood-related relatives have some of these disorders, there may be a genetic indicator in their blood makeup that says that they're a person who's likely to have those disorders as they get older too, because they often don't show up until mid-adulthood to a little bit later in life.